Good afternoon. I'm Dr. Anthony Levinson from McMaster University. This is my colleague, Dr. Richard Sztramko, geriatrician. And we are here today at our third live event for the iGeriCare.ca initiative. Today's live event is covering off responsive behaviors, understanding and managing challenging behaviors in people with dementia. So welcome. Dr. Sztramko and I were really pleased with the response so far to our live events and to the iGeriCare.ca website. We've had over 22,000 people come and make use of our online lessons, and many viewers participating in the live events or watching the archives. Just a reminder, you can participate in this video, you already know if you're watching it live, through iGeriCare.ca/events or through our Facebook page. And if you can continue to post questions either through the iGeriCare.ca events chat box or by sending in your comments and questions through Facebook. So without further ado, let's cover a little bit of background. And of course, like many things in medicine, we make up lots of different words and expressions just to confuse people. Richard, tell us a little bit about the different terms that people may have heard with respect to challenging behaviors in dementia.
Sure. I think the most common one that we've heard for about the last 10 years or so has been BPSD, or behavioral and psychological symptoms of dementia. Now, it's a very broad term. And so I think, what was originally intended was to say, hey, there are the problems with dementia where people have difficulties with their memory and thinking and visuospatial function and all of those things, which are cognitive problems associated with dementia. And then there's this other category, which is a whole bunch of things. And so the behavioral and psychological symptoms of dementia can include things that we've discussed already. So apathy, anxiety, depression, and then things that are different than that, hallucinations, delusions. And then we get to this other kind of classification of behaviors where people may be agitated or aggressive. They may have hypersexual behaviors. They may have very repetitive behaviors. And so we'll call those responsive behaviors. And the reason that this term is important and probably a little bit more useful for both clinicians and caregivers and the patients are that the behaviors can happen in response to something. So instead of just being something random, oftentimes there are things that take place in the person with dementia's environment that cause them to act that way. So for example, they may get agitated and aggressive, but they're really experiencing pain in their knee or pain from a medical illness, or perhaps they had some sort of infection or something and that has triggered them off. So I think that's a much more helpful term because it specifies not only what's happening with the behavior, but what's causing the behavior. And if you understand what's causing the behavior, then you can perhaps modify the routine that person goes through or modify their environment so that they're less likely to experience that behavior.
So I think, we're definitely seeing a trend over the last few years that more and more people prefer the term responsive behaviors. Sometimes people talk about that being more person-centric, that you are trying to understand why might the person be responding in this way. Is their behavior related to something in the environment or a person or a trigger that they might be responding to? But some of the other terms that are maybe more medical or clinical that you may hear are behavioral or psychological symptoms of dementia. The other one that sometimes people use is neuropsychiatric symptoms, right. Neuro being brain and psychiatric mind symptoms. So you've mentioned a few of the responsive behaviors. What are some of the more challenging behaviors that fall in that category that caregivers, talk to you about?
Sure. A big one is agitation or emotional lability. And so all of us experience that day to day. You may be exposed to something that causes you to get angry or a little bit frustrated. Now, when somebody has a dementia, they may lose the braking mechanism in their brain to kind of keep those emotions under control, and they may become more emotionally responsive with a really small stimulus. So you might have been mildly aggravated before you had dementia, but after you have dementia, you might actually get quite upset and start yelling over something that's simple.
It's like the problem with the filter.
Exactly. Yeah, and oftentimes we'll find that happening when, let's say, a caregiver is suggesting that the patient is having a problem, or the person with dementia, rather, is having a problem with their day-to-day activities, or pointing out that they might not be as sharp as they used to in certain areas. The person with dementia might get very defensive and agitated and upset surrounding that.
Two of the other types of symptoms that I often get called upon to see are hallucinations and delusions. Maybe say a little bit about what kinds of things people might notice with respect to hallucinations or delusions.
Sure. And I'm not sure I would qualify these per se as the responsive behaviors, because the hallucinations and delusions aren't generally a result of what's happening in the environment. They're more a result of the damage that is happening in the brain. So hallucinations are perceptual abnormalities. So people can see something that's not there, that other people do not see, or hear things. Occasionally they can feel things or smell things. But most commonly, what we will see in people that have dementia are visual hallucinations. And slightly less commonly would be the auditory hallucinations, or things which people hear. People can see animals or insects. They may see people. Occasionally they'll describe children. And those would be more common in advanced stages of most dementias. So Alzheimer's disease, you usually would not get that earlier, but people that have dementia with Lewy bodies can get that early in the course of their dementia. So very distressing to see for some people. And so some people will see them and not be distressed about these things that they're seeing. So I'd say the most common hallucinations that people get are visual in nature. There are less well-formed hallucinations that people experience as well. So people that have Parkinson's disease with an associated dementia might just see shadows passing through the periphery of their vision, which would be something that's more common. So they can take on a bunch of different forms.
We would call that like an illusion, where there's something in the environment. Maybe somebody sees a broom in the corner and misinterprets it as a person. And again, there may be a behavior that arises because of a hallucination or an illusion. So somebody may get frightened thinking there are snakes on the ground or animals, and they may walk away from a situation. So as you say, the hallucination or the delusion may not be the behavior, but there may be a behavior because of it. So with delusions, some of the more common delusions. So a delusion is really a fixed false belief. So somebody thinks that the mafia is out to get them, or, and that's why I say it's often what we call paranoid delusions, where somebody feels like they're being targeted. There may be a safety concern. They may be convinced that people are stealing from them or hiding things. There may be a memory problem. They've forgotten it, and they just assume that it's been stolen. So sometimes I think delusions may be likely to lead to some type of responsive behavior, where the person is worried or concerned for their safety and may lash out. So
I think the most common ones that we see in clinics are those of harm. So exactly as you're saying, someone's trying to hurt you or harm you. Potentially infidelity, where they're really worried or concerned that their partner might be unfaithful to them. And then theft, so being concerned that somebody's trying to steal something from them. And it can happen that hallucinations and delusions overlap. And so people will see something and be concerned.
Make up a story that fits the
Yeah.
hallucination.
So they're seeing somebody in the room and that person is out to get them, or that person is trying to steal something from them. So there can be overlap between the two.
I guess one of the important things that we also emphasize, if somebody develops hallucinations very quickly, like within a day or two, it could be an important sign of delirium or confusion caused by a medical illness, and we do see that quite quickly. So again, if it comes on slowly and is more typical, and it's not the first time, then it may be part and parcel of the dementia. But if it's very uncharacteristic and somebody is reporting a new onset of hallucinations, it could be the marker of a medical illness, like a urinary tract infection or a pneumonia kind of thing.
I think that's a great point. Anytime in dementia things start moving fast, you have to be really concerned and always consider, as Dr. Levinson is saying, some sort of medical illness or something that's not a slow neurodegenerative process.
So let's just talk in broad terms, very simply, about some of the non-medication or non-drug strategies that people use. But I think it would be good for us to go to questions relatively soon, and I suspect some of these will come up, and medication or drug strategies and non-drug strategies will probably come out through some of the questions. But maybe just a few key points about some non-medicine strategies that might be useful.
Yeah, I think the first thing that we always say is look around and see what's taking place before the behavior happens. So if the person, let's say, is getting a bath and they're being exposed completely, and that's when they're getting agitated, then you have to think, well, what's happening throughout the bath period? And you and I wouldn't want to be exposed in that experience. So it's not going to change just because you have a dementia. And so let's say an appropriate intervention is just bathing them using a sponge bath and only exposing the parts of the body that need to be washed. They've actually done randomized control trials in that, and shocking, people that get a selective disrobing technique have less of a behavior. So just being specific, understanding what's happening before the behavior arises and what's happening in the environment, as well as any of the healthcare providers or caregiver activities when the behaviors are happening.
Sometimes people, like caregivers, it can be helpful to keep a bit of a diary, and you may not be, sometimes it can be obvious what a trigger is. Oh, every time that my loved one has a bath, but it's not always easy to tell. No. So sometimes keeping a diary of when some of the behaviors occur can help you to spot patterns. And I think, as you said, paying attention to the person, their needs, the environment, and trying to figure out what might be the trigger. So.
Sometimes people will become upset if they're having a difficult time processing a lot of information at the same time. It can become really agitated when they're out in public if they're all of a sudden put in a situation where they have to talk to a lot of people. And so that might be a situation where you'd want to minimize exposure to that setting, which makes them upset. So avoiding triggers in that sense is very important.
Kind of anticipating situations that might make things worse.
Not overloading people with your expectations of them. And then to your point about keeping a diary of when things are happening, oftentimes these behaviors are common to occur, between 4 o'clock and 6 o'clock in the evening, and people will tell us, and that's common. It's called sundowning, and we can talk a little bit more about that later. But if you take a diary and are very diligent about understanding when those things are taking place, then you'll see these patterns emerge and understand that they're actually quite common. I think trying to avoid triggers, it's hard being a caregiver. So monitoring your tone and your response to the behaviors can avoid escalation. So if there's an abrupt emotional response on the part of the person that has dementia, if you can monitor and regulate your tone and keep a neutral body language so you're not getting upset and aggressive, then that can prevent things from escalating further.
So much easier said
Yeah.
than done.
Oh, yes. No.
But you're absolutely right. There's, and I guess there's a whole teaching approach called the gentle persuasive approaches, and it's in part, can you maintain your cool? Can you not get as frustrated as you might be? And keep calm and carry on, so to speak.
Absolutely. And I think the indirect approach, to your point, part of this is, instead of becoming angry or frustrated at the person and their behaviors, thinking of something that might distract them from what's upsetting them at the time. So listening to some music or getting them a warm cup of tea. Can I make you a cup of tea? Would you like a warm glass of milk? Can I get you some cookies? Oh, what's on television at this time? And if you know something personal about them, their personal history may be something they'd be interested in. So if they were a keen historian, what are your thoughts on the Spitfire airplane or something like that? And I think that gets into knowing and understanding the person before they had dementia. Getting back to your point about a person-centered approach, the more you understand about their personal narrative and what they've been through, all of that stuff doesn't go away. It becomes less apparent the further the illness goes on, but there's still a lot of those memories and almost reflexive behaviors. So I think that's also helpful.
Good way to engage them.
Absolutely. Yeah.
All right. Well, let's go to some questions now, and we'll take the first question now. My dad is in a home on a dementia unit, so I guess in a long-term care type of situation or nursing home. What can we do when he refuses to let the aides give him a shower? You kind of talked a little bit about some of the challenges that can occur with bathing, and so any sort of strategies that sometimes work in this case?
I think sometimes there are and sometimes there's not. So sometimes you have to provide that person with space, and it's less than ideal, especially when it comes to bathing. But I would say, how well can your dad express his feelings or concerns at this point? Can he describe any specific reasons why he doesn't want to have a shower?
So trying to understand if there are...
Is it that the temperature of the room is too cold? Is it that there's not enough lighting? Occasionally, could you change the between a male or a female caregiver to make him...
if the personal support worker or the aide. I think sometimes too there's people may have their favorite personal support workers or aides that they connect with, and so they may have a better relationship and a better chance. And then I think what you suggested before, if the person is able to communicate the things that are troubling them, great. If not, maybe try something like minimizing the exposure, starting with a sponge bath, and maybe there's good days and bad days, and you can pick a good day with a person they like and try a sponge bath and see if that method works. But there is not always an easy answer.
No. And instead of being rigid on expectations, so they have to have a bath 4 times a week, it might be taking your time, or taking the time to really give them space to go through a routine slightly slower, and maybe it only happens twice a week. It's more of a harm reduction approach in that sense.
There's sort of a fallback or a comeback to that it sounds like one of the things that's an inhibitor is that the person is worried about soiling themselves, I think, during the showering, and incontinence can be upsetting and embarrassing. So probably trying to do toileting before the shower or the bathing might be one approach there. But again, it may be there's maybe not an easy answer, but that would be one approach that might work.
And I think the personal support workers that are on the ward, or the nursing staff that are on the ward, if you come up with some of these ideas, they may be responsive to the feedback that you give them. And they themselves might not be trained in managing responsive behaviors. And I think that's important to note too. There's not one curriculum that the personal support workers receive. They're not all educated in exactly the same way. So the more that you're able to learn about these behaviors and instruct them, the higher the likelihood of success, I think.
And I think that's generally been considered to be a real challenge in terms of the education of medical students, residents, physicians. We don't have necessarily a lot of training in geriatrics and dementia, and I think the same goes for many of the people working in long-term care or nursing homes. They may not have a lot of training. There's often a lot of staff turnover. So again, it is one of our rationales for iGeriCare is to help the caregivers to learn some of these key messages.
And back to your point about, let's say, the gentle, persuasive approaches. So that's an online learning system for formal caregivers, nurses, doctors, and personal support workers to learn. So if you feel there's a lack of understanding on the part of the formal caregivers, then you could point the institution that you're dealing with towards that resource to try and help educate them.
So we have another question, this one from Alberta. The person saying their mother is on in a long-term care or dementia unit. She packs and unpacks her belongings sometimes several times a day. And sometimes this includes even moving furniture around and moving furniture out of her room. The person's wondering, how can I get her to understand that she may actually injure herself and to not do these behaviors?
I mean, that's a real challenge, and the downside certainly is any risk of injury. So you'd really want to minimize whatever she's doing to the point of personal risk. But in terms of unpacking, that might be something that occupies her. And if she doesn't feel distressed while she's doing it, it might actually be contributing to making her calm. So if it's the furniture side of things, it's really the risk because it's heavier and moving furniture is, more of a challenge. Then perhaps it's a question of trying to anchor the furniture and let her unpack the less heavy items, because that might be providing benefit. There are people that we've seen. So for instance, somebody that was a secretary or an administrative assistant coming to the nursing station all the time and appearing agitated and frustrated, but people knew that she was an administrative assistant, so they sat her down at a keyboard and allowed her to type. And so she started typing, and that took away a lot of her distress or anxiety. And this might be a similar situation. If you force her to stop doing all of it, it might actually have a bit of a negative outcome. So
try and identify, if you can identify the positive things about it. Maybe she was somebody who enjoyed traveling and there's packing, or maybe it is something that, is she expressing some of her frustration with living there and is wanting to leave? I think, again, it's trying to understand what is the behavior a response to. Are there particular positives about it because it's a diversion? Are there ways that you can either distract when there are maybe things that are potentially more dangerous, like moving furniture, or come up with creative workarounds? Like, can you bolt the furniture or remove pieces that could be problematic?
And I know that's easy for me to say because I'm not the person that has to clean up everything that she's unpacked. But often in these situations, we try and look for any positive outcome associated with it and only really intervene when there's a large amount of risk.
And it should be said too that one of the types of behaviors that can occur in dementia is, I think we referred to it in another lesson about perseveration, sort of repetition, doing the same things over again. So it's hard to know whether the packing and unpacking has become a bit of a habit from that standpoint that relates to a repetitive behavior rather than there being particular meaning around the packing itself. So, here's another question about, you referred earlier to sundowning, and that would seem to be a good topic, because I think a lot of people use that term. Does a person sundown at the same time each day? So maybe say a bit more about what sundowning is and why we think it occurs, and whether it happens like clockwork.
Absolutely. The exact time, so it doesn't have to happen at the exact time in terms of 5:30 every day, but between those general hours. I'm not sure of the physiologic mechanism, whether it's related to fluctuations in the level of cortisol or circadian rhythms. We're not exactly sure, but people tend to have worsening cognitive impairment at that time. So they may have worsening memory. Their attention decreases, so their ability to stay in conversations, their ability to follow commands may get worse. And then some of the other agitation may take place, or pacing. So many of the responsive behaviors we kind of cover in the lessons, but repetitive walking around the floor, or even the hallucinations that they experience might get worse at that time. So I wouldn't say it happens at an exact particular, an exact time of day, but it happens within that window generally. And maybe it's 3:30 for some people, and maybe it's 7:30 for other people, but closer to the end of the day is when people will experience that sundowning effect.
Sometimes the people's sleep cycles and day-night cycles may be off in dementias, and if they wake up in the middle of the night, I think it's generally common that they may be disoriented and may not be aware of where they are, and may have behaviors in response to that. They may be frightened about losing track of where they are.
And it usually doesn't happen in people that have mild cognitive impairment or a milder dementia. You'll usually see sundowning much more frequently when people have moderate or severe dementia.
Yeah. So here's another a very good question, a challenging one. What would the psychological understanding be of why a person with dementia would treat their primary caregiver, who's maybe a kind and caring, concerned primary caregiver, why would they treat that person potentially very badly, but maybe react well to other loved ones who either rarely visit or aren't involved in their care that often? So this person's saying they've seen that often with parents with dementia, and so they're saying it seems like a bit of a common response that the person with dementia may be more mean to their sort of main care partner and treat other people, with more respect.
I'm not sure, right? This would only be a guess, but usually the things that you experience are just more exaggerated when you have a dementia. So I don't think it's that infrequent for our immediate family to see us at our worst, and potentially we might feel more comfortable showing sides of ourselves that are less desirable to our immediate family than to people that know us less well or see us less frequently. And I'm wondering if that's just an exaggerated response to the normal life circumstances that we see in people that don't have dementia. I'm not sure if you have any.
Yeah, I don't think there's an easy answer to it. I would agree with them that it's not necessarily an uncommon phenomenon. In part, it's probably because the main caregiver is also probably experiencing some good interactions, but they're having that many more interactions, and some of them may be more challenging. They're depending on their primary caregiver role and strategies that they're using. They may be one that is, say, setting more limits on the person with dementia, or often more in confrontational types of situations. I think it does highlight one of the challenges that can occur for care partners is, not everybody has necessarily had a really smooth relationship with their parents growing up, and you may be in a position as a caregiver of having to care for a parent with dementia when you didn't necessarily have a very loving relationship with them. So that can be a real challenge as a caregiver, which is a stressful situation at the best of times, and you may be feeling resentful as a caregiver, and it may be doubly the case if you didn't have a great relationship with that parent growing up.
I think that those are the hardest sets of circumstances that I've seen for caregivers, because there's no positive reinforcement for some people while they're caregiving. So it's definitely a challenge.
So we've got a longer question here. My mother's in an assisted living facility. Usually when I visit, she's in bed, resting, and mostly uncommunicative. She doesn't want me to bring her flowers. She feels she has to take care of them. She no longer wants us to phone her because the ringing of the phone makes her anxious, and she has no ability now to actually call out. Is there anything siblings and I can do to encourage engagement with her surroundings? Staff's been diligent in trying to get her involved in activities for the past year and a half, but although compliant, she usually declines and wants to return to her room. Should we be trying to coax her to do more things that she doesn't want to do? So this is a really good question that ties in with the discussion of apathy, I would say. What are your thoughts on this?
I think so. The first question we always ask when we don't have all the information is this apathy, or is this related to depression or anxiety? And so those are the things that these are the types of situations where I'd want a bit more information first, and saying, is she having more sad thoughts? Is she feeling down? She's lost interest in activities that bring her pleasure. She can't concentrate as much. She's feeling excessively guilty, or especially thinking about death more frequently, actively expressing thoughts of committing suicide, or other non-specific symptoms like experiencing pain. We talked a lot about these things in our last live event. Yeah. And so if that's not there, and there's no medical illness there, and the dementia is progressing, then we'd say that's apathy. That's the lack of desire to get up and perform goal-directed activities. So
if she's not that distressed by it, if the distress is mostly from the family and the staff, then if it is more apathy than depression and anxiety, then it's okay not to coax her. I think the idea is, if you can engage her in activities that she enjoys, great. But if she is wanting to opt out and doesn't appear to be depressed, then it's okay to let her not do things. So I guess there's no one right approach, but it isn't necessarily the case if she has this apathy that she's necessarily sad, and it may be fine just to kind of leave her alone. So here's another question that came in. Can a change in behavior occur without notice? Like very suddenly, the person says, almost like a split personality. 1 minute they're one way, and all of a sudden they're another.
That's not very common. And we talked about if anything changes quickly in a dementia, then you have to go back to the drawing board and consider whether or not this is related to an acute or short-term confusional event called delirium. It can be associated with medical problems, pain, dehydration, constipation, urinary retention where the person can't empty their bladder. There's a lot of other causes that we wouldn't get into, but certainly
in the absence of any kind of obvious trigger, like a change in the environment or a particular person, or
it would be much less common.
It would be less common, and if the person isn't that communicative because they've lost some of their language, then you would worry about something like an extreme type of migraine headache, or a headache or something like that.
Absolutely,
So here's a different comment. My loved one seems to be able to turn it on, appears more lucid when they go for a doctor's visit, but then is confused after we leave the appointment.
And that's really interesting, because I don't see the people when they go home for their appointment, but I will say that doing some research protocols, I actually had the chance to go back and observe people that have dementia multiple times in the same day. And it was interesting to see the fluctuations in their cognitive abilities within the same day, because often we'll only see them once as a caregiver. So cognitive abilities can fluctuate naturally. I think that's the benefit of standardized tests that really stress the brain. So a good one, if there's just some mild cognitive changes, is the Montreal Cognitive Assessment. And that's where you can't really hide things or turn it on. The types of questions that are asked or stress your brain enough that if there are problems and you are having confusion, it should be able to show us where you're having problems. So one is there are natural fluctuations in cognition that occur with people that have dementia. In particular, people that have dementia with Lewy bodies fluctuate a lot. There are normal fluctuations with people that have dementia, but then also we can get around that if you're concerned that they're not presenting their true cognitive abilities to their doctor by doing these objective cognitive tests.
I think it's highlights as well. Mostly when we're in the clinic, we're seeing just a small snapshot of somebody, and it highlights the incredibly valuable perspective of the caregiver that is spending the other 23 and a half hours.
Yeah.
So, it's great if the loved one is allowing you to attend the doctor's visits, because it would be really important for you to offer your perspective on some of the day-to-day functional and cognitive challenges. So that is why getting what we call collateral history from care partners is so important, because you only get a little snapshot in the office.
And you're allowed to discuss those things if you have concerns as well. And we don't do any assessments in cognition without asking collateral from the caregivers. So it's a very important part. Kind of need everything together. What the person with dementia is saying, what the caregivers are saying for collateral history, and objective cognitive tests, to put it all together and figure out what's taking place.
I think the other thing is the context sometimes around a doctor's visit or a specific activity is familiar to the person.
Yeah.
So, unless the doctor is asking other types of questions or doing more detailed testing, people have a kind of a sense of this is what I'm expected to say or do in this.
Or having a charming personality. Some people just have charming personalities, and those will outshine any of the cognitive problems.
Cover up some of the weaknesses.
Exactly. Yeah.
So here's a question. My mom does not like supper time, and the person thinks it's associated with when they have to leave. Would it be better to not say goodbye and just sneak out? So I'm thinking this is somebody whose loved one is in long-term care and has like a meal. So what would you suggest there?
I think there's no great answer, and a lot of the responsive behaviors as well. It's great that you've limited this down to being associated with dinner time and you leaving, and then it's a question of, I think, experimenting and seeing what happens. So if they have really bad short-term memory problems, then they might not actually remember the fact that you left. In which case, if you leave and you avoid causing them distress or being upset, then I think that's completely reasonable. And there's no easy answer for these responsive behaviors or emotional patterns. So I would try one thing. And if you feel okay with that and it's not causing distress, or it's minimizing the distress that the person experiences, then it's completely reasonable to try that and see what happens. And then ask the staff afterwards what happened. And then if you do that all the time and it reduces her distress, then I think it's a completely reasonable course of action.
I think this is a relatively frequent scenario too, and I think trying to get to know the routine at the facility and figure out the meal times. Often, what is suggested here is don't completely sneak out without saying goodbye. Prime the staff that you're going to leave when they sit down for the meal. Once they're sitting down and they have sort of the diversion and distraction of the meal, then you might even just sort of whisper in their ear, I'll see you later.
Sure.
Something like that. So again, you sort of, you use the advantage of there being some distraction and try to minimize it, and also highlight that, you'll be back again. So, there's no one right way to do it. Okay, we got one or two other questions. This is a person who's a volunteer at a long-term care facility and also at a hospital. They do a lot of talking with residents who are having difficulty coping and have exhibited behaviors. the hospital, I guess, has some form of counseling, but not the nursing home. They're wondering about any recommended readings or resources. I can suggest there's the Alzheimer's Society has a guide called Shifting Focus, which is a good recommendation, not just for somebody working in long-term care, but for care partners generally. And it actually kind of covers some of the things that we've talked about today. We do have our lesson 8 refers to the apathy, so would be appropriate for the one person and the resources associated with that. And then lesson 9 is the one where we talk about more the responsive behaviors, and we have a few resources there, including the link to the Alzheimer's Shifting Focus. Any other resources or readings that you would recommend?
I think you've covered it.
Okay.
I think those are great resources. And then just if you're looking for the care team in the facility to be better educated, would be the gentle, persuasive approaches side of things. So,
and actually, one other really good resource that we just came across was out of Mount Sinai in Toronto, is an app called Dementia Advisor, and it has a series of scenarios that give very helpful, very real-world, realistic scenarios with some of the same suggestions that we've talked about today, things that might be helpful in terms of those kinds of approaches.
I think, too, checking out the Center for Aging and Brain Health Innovations website to see all of the different new technologies that are coming out as well, and educational applications. There's a lot of great things that it's been interesting to see the explosion of interventions for dementia caregivers. So there's lots of new technology that's coming out quite frequently, and educational apps and educational platforms. So,
and I guess it's interesting, we're at the 42-minute mark of a 45-minute one, and we have not talked about medications for responsive behaviors. And honestly, in part, it's because really medications are typically a last resort. And but do you want to say, in a brief period of time, say anything about the role of medicines? And
sure. I think exactly as you're saying, it's a last resort, but it is commonly required. And we don't usually use them unless the person's at harm to themselves or harm to the people around them, or the degree of distress that the behaviors are causing are unmanageable on the part of the caregiver and the person with dementia. So if you have complete sleep-wake reversal and nobody in the house is able to sleep for weeks on end, that's not a tenable situation. The same thing if people are striking out and being very aggressive. We've gone through all our procedures. We understand that there's no specific antecedent set of factors that are starting it. They don't have a medical illness. There's nothing else that we can treat, like pain or dehydration. So we've gone through our whole process, and what we're stuck with is something that's a very severe behavior. Then we'll intervene. Commonly, the medications we'd use to intervene are antipsychotics. So risperidone, Haldol, quetiapine are common ones. We won't go into...
I'm feeling that maybe a future live event is talking about the different medicines, but I guess one of the bottom lines is really the scientific evidence, the data behind the effectiveness of medicines for the management of agitation and challenging behaviors in dementia. There's not great science behind it, and there's side effects. So I think we would encourage you to go through lesson 9, which does talk about the different classes of medicines, and then maybe a future live event on the topic.
I think so. One thing just to mention is that they do work very well for certain people, and sometimes the science is lacking because of the way we measure the outcomes. And so, if we measure all of the BPSD and we don't focus in on specific behaviors with specific medications, we run into problems. So there are side effects associated with them and adverse events, but for some people, they're absolutely necessary. And for some households and some caregivers, they're life-saving.
Yeah. Okay. So that's all the time we have for today. Any questions that we didn't get to, we'll try to answer on our Facebook page. Really, please take a moment to fill out the brief survey. It's super short, wafer thin, and we're really looking for more input into other topics for live events and anything else, other suggestions you have to improve the experience. A couple reminders. Our next live event will be on Wednesday, December 12th at 1 p.m. Eastern Time. In the next period of time, we will put a copy of this video on the website, which you can access at iGeriCare.ca/events. I would really encourage you to subscribe to our email newsletter, which will also keep you aware of when new live events are coming. But use the survey to tell us what you'd like to hear more of in future live events. At this point, I would also like to thank our sponsors. Funding's provided by the Canadian Centre for Aging and Brain Health Innovation, which is powered out of Baycrest, the Jerris Centre here at Hamilton Health Sciences, McMaster University, and the Hamilton Health Sciences Foundation, and the Alzheimer's Society of Hamilton Halton. I would be remiss if I did not remember to say teamwork makes the dream work. So I want to thank Stephanie, Jamie, Mike, and our whole team at the Division of E-Learning Innovation for helping put together these live broadcasts. And we look forward to seeing you again December 12th. Thank you very much.
Thanks.